Can you see my screen?
Yes.
All right, so next one is, let's do Myasthenia Gravis. That's under neuro and peripheral nervous system. I will only cover Myasthenia Gravis this time. Guillain-Barre will follow next semester. Okay. Myasthenia Gravis is a autoimmune disorder affecting the neuromuscular system. What happens is, let me put it this way. Okay, so pardon my drawing of a synapse. So this is a neuron. So this is one end and this is another end. Okay, and then this is the other end of another neuron. So as acetylcholine so acetylcholine is a neurotransmitter. It's responsible for all muscle contractions. Dopamine is different. We'll do dopamine another time. Dopamine is involved in Parkinson's disease. So basically how our muscles work is we have neurotransmitters that make muscle contractions possible. In order to control those muscle contractions so they become purposeful. So let's say I want to pick up this bottle of spray so I can clean my seat. I'll pick it up. So acetylcholine is traveling through from one muscle to the next through the neurons. And then dopamine levels help me control my movements. Acetylcholine travels from one synapse, from one neuron to the next. And these are all fast, of course. So there are neurotransmitters found here. Receptor sites, sorry. So as the acetylcholine is passed from one neuron to the next, there are receptor sites here which receive the acetylcholine. What happens in myasthenia gravis is you develop antibodies against these receptor sites right here at the tip of, at one end of the neuron. What happens is they destroy them. Not all of them are destroyed though. So let's say half of them are gone. So you have 50% receptor sites. There's no problem with the amount of ACTH. Not ACTH, ACH. So acetylcholine levels are not affected here. Dopamine is not affected. So you have a steady amount of the neurotransmitter, no shortage of the neurotransmitter, acetylcholine. The problem is with the receptor site. So you have antibodies. This is obviously a autoimmune disorder. So you develop antibodies against these receptor sites, destroying them. So now you end up with less receptor sites. So now, if you're doing any movement repetitively, so give me examples of repetitive movements that you do every day. Like what are you doing right now?
Eating.
Okay, chewing when you're eating a meal. That's repetitive, correct? When you're walking from school down to the subway, is that repetitive, walking? When I'm talking in class, is that repetitive? Okay. Breathing, is that repetitive?
Yes.
Okay. So any repetitive movement become or causes extreme weakness, because this is the main problem. You have acetylcholine, which is again necessary in order to stimulate the muscle to contract. But moving from one neuron to the next of a muscle, the problem is there are less receptors. So therefore, can it keep up with the demand of muscle movement? Can it keep up with the repetitive muscle contraction? If you have less receptors here, so it'll be like um, you're going for COVID-19 testing. This testing site, you have 1,000 people, but then there are only 500 uh, testing sites. So will there be eventually a backlog? Yes, there would. It can't keep up with the muscle contraction. So same exact thing here. You have less receptor sites than you do acetylcholine. So this would explain our symptoms, which are hallmark signs in myasthenia gravis. There is a weakness with any repetitive movement, meaning the more you do something, the more weakness will ensue. But when you rest, though, the weakness goes away. And then when you do the repetitive movement again, you notice the same exact weakness after a few minutes. Are you following so far? Any question? Hello?
Oh, no questions yet.
No.
Okay, all right. Who gets it? There's really um, no set. I mean, there are, we don't know who can get this. Again, it's an autoimmune disorder. However, incidents are the following. We have in women, the onset's between 20 to 30, and then in men, they get it between 60 and 80. I honestly have only seen one case of myasthenia gravis, and it was a really big guy. Um, no, middle-aged guy, 50s, and he was about maybe 300 pounds. And then talk about myasthenia gravis. This guy could not support his weight at all, and because of his weight, so a few of us did get back injuries, because ambulating these people, when they get up and then they will just buckle all of a sudden during ambulation. Um, this drawing here is a lot better than what I did. So this is the receptor sites, and then you have the acetylcholine there. So the problem again is you have less receptor sites, because these receptor sites are destroyed by the autoantibodies. And this is what's responsible for the progressive weakness with any repetitive activity. Most of the symptoms, though, have you ever heard of Guillain-Barre syndrome?
Yes.
Okay, in Guillain-Barre syndrome, we'll like I said, we'll talk about that next semester. The pattern of the weakness is ascending, starting from the feet, going up to your diaphragm, and then eventually to your face. In myasthenia gravis, it's the opposite. This starts from the top. It starts actually from your eyes, goes down to your mouth, your throat, your diaphragm, and then below. Typically, the danger here is once it hits the diaphragm, then the patient will go into severe respiratory depression, because it's breathing
What? We
a
have a break
repetitive
now.
movement. That was not me. All right, whoever that was. Okay. What were we saying? Yeah, we are recording. All right, let's start over.
You talk about your eyes,
Right.
your mouth.
Yeah, so the symptoms here start from the eyes. So the most common complaint of the patient is double vision. And they'll also say that they can't finish through a meal because they get tired. Um, some will complain that they will have choking episodes because during eating, of course, you're chewing, right, and swallowing. These are repetitive episodes. You get tired, and then let's say the weakness ensues right in the middle of your swallowing, so that can be dangerous. You could choke. Um, People also complain of ptosis, meaning eyelid drooping. Their eyes droop, but their eyes, they just can't hold their eyes up. In fact, in my country, because the testing here, we'll discuss the testing called Tencelon Test. Tencelon is expensive, so we have a poor man's Tencelon. It's very primitive, but it works. So what we do is the doctor will ask the patient to follow a pen. So we'll tell the patient, okay, follow this pen before their eyes, and then we'll put the pen up and down, forcing the patient to look up and down. Not their head, just move with their eyes. If they go up and down, and then if they get tired after a few seconds with that, then that is a positive Tencelon test without using Tencelon. Okay, so that's third world. Um, yeah, I mean it works. But anyway, the symptoms again are bulbar. Bulbar is referring to a group of cranial nerves around the face. These are again involved in talking, chewing, swallowing, right here. So these muscles are involved in these activities right here: talking, chewing, and swallowing. Those are the bulbar cranial nerves. So cranial nerves 9, 10, 11, and 12. Although some patients do present with muscle movement, it's really the bulbar muscles that cause the patient to go seek medical attention. But later, these patients will have trunk and limb weakness as well. Although uncommon, these patients do have respiratory failure complications, but that's rare. It's not like Guillain-Barre syndrome, which really affects the diaphragm. Myasthenia gravis typically doesn't. But I'm not saying that these people won't. Okay, they do get some of them do get pretty serious and go into respiratory failure and will have to be intubated. Let's go to testing. Testing is done using I mentioned the Tencelon test. Before we go to the Tencelon, these are other diagnostic procedures, but they are not specific to myasthenia gravis. What the repetitive nerve stimulation and EMG does is help us rule out other causes. Maybe it's a spinal nerve problem, not a autoimmune myasthenia gravis problem. With EMG, you'll the doctor will apply a electrical nerve stimulation on a proximal to a distal part of your body. So let's say on the thigh, and then he'll put the other needle on the lower leg, for instance, and then apply the electrical impulse. If the impulse travels from the proximal to the distal, then meaning there's a connection between the nerves, meaning the impulse traveled from the thigh all the way to the leg. So that will rule out that's not myasthenia gravis. And it will also rule out Guillain-Barre Syndrome, because Guillain-Barre Syndrome, it's another autoimmune disorder which causes demyelination of the nerve fibers. Myelin is the myelin sheet, the insulation cover of our nerves. This is the specific test for myasthenia gravis. So since the pathophysiology again is we have enough acetylcholine, but we don't have enough acetylcholine receptor sites because they were destroyed by your antibodies against them. So what we'll do is give you a anticholinesterase. An anticholinesterase is a drug that will destroy acetylcholine. It's a short-acting drug. The one used for Tencelon testing is edrophonium. The brand name of edrophonium is Tencelon. So we call it a Tencelon test. So this is the procedure. If you read it, we'll give you 2 milligrams, for instance. So if the patient comes in with symptoms of myasthenia gravis, so we'll do the testing. We'll give you 2 milligrams. And if there is, and then we'll ask the patient to do something repetitive. And if there is improvement in the weakness, meaning instead of getting weak, you get stronger instead, then that means that is a positive Tencelon test because you responded to edrophonium. Does that make sense? You have a question?
I was typing. Does that make you, if you're stronger, you're positive for MS?
Not MS.
Myasthenia gravis.
Myasthenia gravis. MG. Okay. Don't say MS. MS is multiple sclerosis. That's a different problem. Okay. Again, anticholinesterase medication, because we have to destroy acetylcholine at some point. Otherwise, we will never stop, our muscles will never stop contracting. So we have acetylcholine, which makes, again, muscle contractions possible, correct? And then anticholinesterase is a no, no, that's not it. Yeah, anticholinesterase is a natural enzyme that will destroy acetylcholine, okay, allowing us to stop muscle contractions. Okay, so now we're gonna give them an anticholinesterase inhibitor drug, which is edrophonium. So therefore, by making acetylcholine hang around longer, will that help improve the weakness? Maybe I'm not making myself clear here. Okay, let's start over. You see the whiteboard? Teams people, you see the whiteboard?
No.
Not yet. Maybe there's a lag. Yep, I see it.
Yes, no.
Okay, all right. So let's start over. So let me make my drawing better. So this is the, okay, and this is the receptor sites. Okay, so normal physiology is you have acetylcholine here. And these are the receptor sites for them. There's anticholinesterase, which will destroy acetylcholine. And this is normal, meaning we have to stop muscle contraction at some point. Okay, so acetylcholine is passed from one neuron to the next, allowing you to contract muscles. Then, like I said, dopamine will be there to help us control them. That way they become purposeful movements. Anticholinesterase is the substance that will destroy acetylcholine. That way we can stop moving muscle fibers. Okay, we can stop muscle contraction. Because we have less receptor sites, what we'll do is inhibit this one. We will inhibit anticholinesterase. That way acetylcholine is not destroyed, making them hang around longer at the synaptic end. So even though you have less of these receptors, but your acetylcholine is going to be around longer, now sustain a muscle contraction. Does that make sense? Yeah, because, okay, this is what happens in myasthenia gravis again. You have acetylcholine, right? But we don't have enough receptors because they were destroyed by your autoantibodies. Naturally, acetylcholine is destroyed by anticholinesterase every second of every day. So they are passed on from one synapse to the next. But anticholinesterase is also there to destroy them. That way, you don't have an endless muscle contraction. It will end at some point. Are you with me so far? So this is naturally occurring. This is natural physiology. Now, what we'll do is, because we don't have enough receptor sites, why not prevent because there's nothing we can do here. These are destroyed already. The autoantibodies destroyed most of the receptor sites. We can't fix them. They're already gone. What we'll do is prevent anticholinesterase from destroying acetylcholine. That way, if acetylcholine is available longer, can you now sustain the muscle contraction? Yes, we can now. Yes.
Is it that the reaction will be a little bit slower? Because,
No, no, not really. No, no, it's not going to slow your reaction. No, the acetylcholine will be around longer. They'll last longer because you're inhibiting the anticholinesterase. So now you can sustain any repetitive muscle contraction. So back to the test. So let's say you came in with weakness. You haven't been diagnosed yet. It's the first time you're seeing the doctor. Doctor, based on your complaints, says, okay, I think you got myasthenia gravis. So let's do a test. So he'll ask you to do something. Let's say, blink your eyes, for instance, and then he'll give you, when the weakness comes, he'll give you 2 milligrams of edrophonium. If the muscle contraction or the muscle weakness improves, meaning you can now continue with that repetitive movement longer than you used to, then that is a positive Tencelon test. You have myasthenia gravis. Is that understood? Are you following me so far? All right. Now, there's also the test is also done on another scenario. So the first scenario we looked at was the patient was being diagnosed for myasthenia gravis, meaning they're not taking any drugs at all. Are you with me? So that first scenario, the patient just came to the doctor. No medications on board. We gave them the medication and then it improved. Okay. Now let's look at another scenario. Because once we have a positive Tencelon and then you have myasthenia gravis, you will be put on longer acting anticholinesterase inhibitor medications. So edrophonium here is only a short acting. So it does not last long. So when we prescribe medications to you, for you, are we going to give you edrophonium to take every day?
No.
No, because it's useless because it only lasts for a few seconds. What we'll give you is mestinon, neostigmine, which are longer acting anticholinesterase inhibitors. Okay, so let's say you've been on anticholinesterase inhibitor medications for a while now. And the instruction is you will have to take more of the drug if you're doing more activity. So let's say you decide to, okay, I want to join a marathon. While training for the marathon, are you going to need more doses of the anticholinesterase inhibitor?
Yeah.
Yes, because that's more than ordinary, right? So you're going to be jogging for a while. So you're going to need higher doses. So what I'm saying is there's no set dose for a particular patient. The patients learn how to take the drug based on their activity. Meaning if they foresee, oh, I'm walking today, I'm not driving home. Okay, I'm gonna walk home. So do you think they'll need more of the medication? Yes, they'll take it typically 30 to 45 minutes before the activity. In fact, before a meal, because meal eating is repetitive, right? So they'll have to take the medication 30 to 45 minutes before a meal. That way, the drug peaks at around the time they eat or do whatever activity.
All
Sorry,
the drugs,
the what?
all of the antihistamines, 30 minutes before.
Yeah, 30 to 45 minutes before a meal or before any activity that is going to be repetitive. All right, so again, the patient here will not have a set dose. They'll be adjusting their dose, right? Depending on their activity. Now, is there a tendency that we may take too much or too little of the drug?
No, not a good.
No.
Yes.
Is there a possibility? Exactly, there is a possibility because we may overestimate, we may underestimate, right? So what happens is we might develop a crisis. There are two types of crises here. One is called a myasthenic crisis. A myasthenic crisis is a situation wherein we don't have enough of the drug. That's why we go weak. However, there's also a tendency that we take too much of the drug, which is now called a cholinergic crisis. The problem is they present exactly the same with a few differences, but there is weakness. Whether the patient undergoes or experiences a myasthenic crisis, which is not enough of the drug, which results in severe weakness, or they end up taking too much of the drug, which still results in extreme weakness. So can we tell them apart easily? No, because when the patient comes in, they are very weak. So therefore, we need the Tencelon test again in order to tell what are we looking at. Is this patient having a myasthenic crisis or are they experiencing a cholinergic crisis? Are you following so far? Okay, one more time. Because these patients will be adjusting their medication based on their individual activity, because you and I are not the same. Like when I come home, I work out until the dead of the night. I do some gymnastics. I do a lot of have you seen my show on TV? I'm a
Yeah.
personal trainer.
I've seen it.
Yeah, you can see me doing that, right?
They're
Of
not
course.
lying.
Based on how ripped I look.
It's evidential.
Anyway, so so we have different activities. So no two patients will have the same dosing. So they'll be adjusting their dose. So in the course of that, there could be a possibility that we either overestimate or underestimate the drug therapy. So there are times when we end up taking too much. There are also times when we end up taking too little or not enough of the anticholinesterase inhibitor drugs. When that happens, in the case of you don't take enough, which is manifested by extreme weakness, we call that a myasthenic crisis. In the case also of you end up taking too much of the drug, we call it a crisis, which also prevents as exactly the same extreme weakness. Now we have to tell them apart. So patient comes in, doctor does a Tencelon test again, this time not to diagnose because the patient already is, yeah, they already know they have myasthenic crisis. This time, the Tencelon test will help in distinguishing, is this a myasthenic crisis or a cholinergic crisis? Okay, if it's a myasthenic crisis, we do the Tencelon. What do you think will be the response? So I'm experiencing a myasthenic crisis. I have extreme weakness. If you give me edrophonium, what will be my response?
You would improve.
Very good. So I will have improvement of my symptoms because I didn't get enough of the medication, correct? Now the problem becomes, what if it's a cholinergic crisis? I took too much of the drug already. Now when I come to you, you do the Tencelon test. I already have too much of the drug. That's why I'm weak. Now you give me edrophonium. What's going to happen to me? I might go into respiratory arrest. Okay, I will have extreme weakness because now you added even more anticholinesterase inhibitor drugs to me. Okay, very good question. So that's why when we do a Tencelon test for that purpose, to distinguish between cholinergic and cholinergic and myasthenic crisis, we have to have atropine ready. Atropine, right here, page 848. Atropine is the antidote. So this will reverse the effect of the anticholinesterase inhibitor. So this will save your life. 848. So just in case it's a cholinergic crisis, we have atropine vials ready. So we're gonna administer atropine if the response is the weakness gets worse instead of getting better. Are you following up to this point? Any question on Tencelon testing? Okay, again, it's used in two different scenarios. Okay, one is initial testing, and then another condition will be to distinguish between a cholinergic and a myasthenic crisis. Another test that they'll possibly do is a CAT scan. They'll detect a thymoma. There is a certain percentage, not a lot, maybe 10% or a little bit more of people who have myasthenia gravis has a tumor in the thymus gland. But that's not a lot though. That's only a small percentage of the people who have a myasthenia gravis. But they do that anyway. So like I said, the medications which are longer acting, so edrophonium is only used for testing, for Tencelon testing. The regular day-to-day treatment will be pyridostigmine or mestinon. And this is the dosing, 30 to 60 milligrams by mouth every 4. Again, the dosing, again, that's why it's a range because the patients will have to make adjustments here. So early on, they may not know how to use it very well, but the more they use it, they know how their body reacts to it, then they can adjust the medications and then become experts on it. Here's a safety alert regarding pyridostigmine. Look at the side effects here. We have stomach cramps, diarrhea, increased secretions, nausea, bradycardia, and muscle twitches. Take note of the increased secretions. We'll use that later. Especially when we're having a cholinergic crisis.
What about the patients who their diaphragm is going down?
For those patients, we'll get to that when we get to cholinergic crisis. Okay. We'll look at the management. Okay, I stand corrected. I said 45, right? Which is right in the middle of 30 to 60 minutes. So technically it's still right? 45 minutes. But your book says 30 to 60, so we'll use 30 to 60.
That's up under the exam?
Yeah, for exam purposes, because that's what your author says, 30 to 60. But other authors say 45, which is average, right in the middle, right? Table 38.2 gives you your summary of the medications. So every day, pyridostigmine will be your patient's regular maintenance. They'll carry this around. They won't leave it at home because they do go out. They go to work, go to school, and should be regularly taken. The dose again will be changed if the patient's activity also changes. So definitely they'll need more of the drug. If, let's say, they're exercising, here again, take note of the increase in secretions as a side effect of pyridostigmine. I'll explain how that works later under cholinergic crisis. Because this is a autoimmune disorder, they will be put on steroids. So the maintenance dose daily will be low dose, which is 15 to 20 milligrams daily.
That's not steroids?
Yes, they'll be taking these every day. For if they're hospitalized, then they'll be given higher doses of the steroids.
So with
Yep.
regards to the medication, we know that they do it according to their level of activity. But is there a range, like a peak or thing that they don't go over?
Of course, they're not going to take a handful of these. All right. So maybe they'll double the dose if they're increasing activity. The problem becomes, let's say they anticipate that they're going to have an increase in activity. So let's say it rains. Now they can't go jogging. Okay, they didn't check the weather. They prepared to go jogging and then they took double the dose, 30 to 60 minutes, and then it rained. So now they're stuck at home. So what are they going to do? Jog at home? Tiny apartment? Here's the other drug. Neostigmine, which is prostigmine. This one is in IV form. This is only used if the patient is undergo surgery or if they're NPO. Again, the everyday one is pyridostigmine, which is PO. There is an IV form, neostigmine. So this is only used, obviously, if the patient's unable to take anything by mouth. Like say the NPO for a procedure or a surgery, for instance. And because it's IV, this is not given outside the hospital. So this is only in a controlled setting. These are your serious side effects, which is bradycardia and other dysrhythmias. Let's go to immunotherapy. This is referring to immunosuppressant medications. Same medications we use for transplant rejection. The purpose again is to suppress the immune system because these are your autoantibodies. So to suppress your production of against the acetylcholine receptor sites. So you'll yes, these medications again are not exclusive to myasthenia gravis. These are the same medications we'll be using for organ rejection. These are also used in multiple sclerosis as well as in rheumatoid arthritis. So we have cyclosporin, mycophenolate, cyclophosphamide. So different drug classifications. There's another one not listed here, which is more commonly used in multiple sclerosis called azathioprine. The brand name is Imuran, Imuran. But it's not listed here, so we'll only stick with cyclosporin, mycophenolate, and cyclophosphamide. Here are some medications that must be used with caution. They do interactions with the patient's therapy, namely antibiotics, calcium channel blockers, magnesium. As far as antibiotics, they are specifically streptomycin and polymyxin. And here's magnesium sulfate. In the case that the patient does have respiratory symptoms, which again is not very common in myasthenia gravis because the weakness doesn't really reach that far. Then they'll have to be evaluated. What we'll check instead of the pulse oximetry is forced vital capacity. Why can't we depend on oxygen saturation? Why are we basing our evaluation on forced vital capacity? Okay, because this is a problem with the muscle, with the breathing muscle. There's no problem with the lungs. The lung cardiopulmonary system is absolutely normal. So when you check the oxygen saturation, it will actually show normal levels, but then you see the patient having difficulty breathing because it's the muscle, the diaphragm is involved. So therefore, the more accurate assessment will be based on the forced vital capacity. The diaphragm. Yeah. This will be measured using a spirometer. I said spirometer, okay, not spirometry. Yeah, incentive spirometry is that tiny little box you do for inhaling, right, for bedbound patients. Yeah, a spirometer is a different. Spirometry is a different. Sorry, the small device we use is called the spirometer. The machine measuring forced vital capacity is called as spirometry. Other options, which is also used in Guillain-Barre Syndrome, is immunoglobulin and plasmapheresis. We should really change this instead of and. This should really say or. Okay, because you could mistake this as they're going to receive both IVIG and plasmapheresis. No, because they have the same effects. It should be or. IV immunoglobulin, which is IVIG, or plasmapheresis. Now, what is this? IVIG are good antibodies. This is used to treat autoimmune disorders like MG. The cost is very prohibitive. This thing can cost around 1,100. Last time I checked, it's about $1,100 to $1,200 per gram, and the dose is about 1 milligram per kilogram. So, and you'll need about maybe 4-6 treatments. So how much are we looking at? If you weigh 70 kilograms times $1,100, how much is that, Mr. Chen?
70,000. $77.
Yeah, so is that cheap? And you need about maybe four to six treatments of that. What are we looking at? $500,000, right?
More than that.
Well, that's my next question. Now, which insurance company in their right mind is going to cover for this? You know what I'm talking. I mean, I don't have to explain, right? So it's very costly. The alternative is plasmapheresis. Plasmapheresis is like a dialysis machine. So this machine, though, will not take out your waste products like hemodialysis does. This is a machine that will only remove antibodies. Well, it's not technically the antibody. It will remove plasma. So same setup. You need the vascular access. So you'll sit there for 3 to 4 hours. Your blood leaves your body, goes into the machine. It removes your plasma. There's two options here. Either they'll replace your plasma with another person's plasma, so it's like a blood transfusion, or they can take less plasma, not a lot, then just give you saline in return. Okay, so plasmapheresis is also called plasma exchange. So since the antibodies are in your plasma and we can't just take out antibodies, so we'll have to remove plasma and then give you a plasma exchange. Or, like I said, we can remove a little bit of the plasma, not a lot, and then just replace it with saline. Yeah, the fresh frozen plasma. Yeah. Okay, so this therapies obviously are expensive, but IVIG is the most expensive. Plasmapheresis is the next one. These are only used if the patients are hospitalized, meaning they have severe symptoms, then they'll undergo plasmapheresis. Let's briefly discuss plasmapheresis. So if we're removing your plasma, what's in the plasma? Because you're losing plasma here.
GCT, HCG, HGG, HCG.
No, hemoglobin, hematocrit are not included here because those are the cells in your blood. So we're only removing the liquid portion here of your blood, the plasma, where all your blood cells are dissolved in. Not dissolved. You know, when we spin your blood sample in a test in a test tube, it separates the blood. The blood is in the bottom, and then the yellow part is on top. Yeah, so that's plasma. So plasma is mostly water, about 70% water. It's about 25% albumin. So it has water in it. It has protein in it. What else is in there? Just the important parts. Are clotting factors in there? Yes, clotting factors are found there. Are all antibodies bad here? No, only the antibodies we have against the acetylcholine receptors. We have good antibodies there. So in summary, if we're doing plasmapheresis, we're removing your plasma, which contains protein, clotting factors, good antibodies, and water. What will be your potential problems or complications from plasmapheresis? What happens to your blood pressure?
You have nutrition.
We have one patient here. So what will happen to your patient if we remove their plasma? which contains, again, water, protein, clotting factors, antibodies. What potential problems do you foresee after the procedure? One is fluid deficit. What happens to your blood pressure? It's gonna drop, right? You'll have hypotension. Could there be bleeding here?
Yes.
Yes. Could there be infections because you're losing antibodies? Yes. Now, equipment-wise, remember, it's like dialysis. So your blood leaves your body through long tubings. They go into the machine, and then they return to your body. What do they use in order to prevent your blood from clotting while it's outside your body, while it's in the machine? What do they use? They use citrate. Citrate is a preservative, an alternative to heparin for the tubing. So the tubing here used to take your blood out of your body into the machine, and then another tubing back into your body, is lined with citrate. Now, when citrate enters your body, remember we talked about free calcium earlier, ionized calcium? Calcium and citrate are naturally attracted to each other. They can't help it. They will elope. When they meet each other, it's an instant attraction. They'll form a compound called calcium citrate. That is now a compound that's not free calcium. So that compound goes into your bone. What happens to your free calcium levels, therefore?
Low.
It's gonna drop, because where did it go? Into your bone in the form of calcium citrate. So let's summarize. What are problems related to plasmapheresis? Hypotension.
Possible infection.
Infections.
Malnutrition.
What was that? Bleeding problems, right?
Because
Yeah, bleeding. Yeah, bleeding problems. Oh, it's not really nutrition, because the protein we're talking about here is in the plasma, not anywhere else in your body, just in the plasma. So our major concern here is the hypotension, hypocalcemia, bleeding, some extent of dehydration, and possible infections. Here's the cost here. A typical treatment is about 10,000, and that's a really low estimate. Most people start at around 20 grand and up for one treatment. And again, there's a lot of treatments here. Oh, my bad. I said 1 gram per kilogram, right? For myasthenia gravis, it's 2 grams per kilogram. The 1 gram per kilogram I'm quoting is for Guillain-Barre Syndrome, as it's a higher dose for myasthenia gravis. The only side effect from IVIG is an allergic reaction. Or let's say it gets contaminated, then you'll have fever, headache, chills, and myalgia. Again, here's a summary of medications that make myasthenia gravis worse. Table 38.3. We have a new drug now, Aculizumab. When you hear these drugs, when they say UMAB, if they end with that word, these are monoclonal antibodies. Again, very expensive. You heard about the drug, the antibody treatment that Trump received? Yeah, these are monoclonal or polyclonal antibodies. Very expensive. If you thought IVIG was expensive, forget about it. These drugs are not available to common people like you and me. Yeah, he's the president, so yeah, taxpayer money paid for that. If you want everything free, run for president.
You will never know.
Or if you guys don't like either candidate, write me in, okay? Write in Roger Escarda. I'll be your president. All right, here's plasmapheresis. Please read that on your own. I already described it to you. Right after, yeah. Here's the citrate I mentioned to you, causing hypocalcemia. And here is the other problems that result. We have hypotension, clotting problems right here. And here's the citrate-induced hypocalcemia. Here's hypotension. Hypotension, I forgot the nausea, vomiting. These are more related to citrate toxicity. Yeah, these are all complications of plasmapheresis. Here's the hypovolemia, which leads to your hypotension. And here are your management for that. So if the patient is symptomatic from the volume loss from the hypotension, then put them in Trendelenburg, or at least modified Trendelenburg. Give them fluids. All right. And this part here is about the access related complications related to the access, because like I said, this is like dialysis. So you'll have a catheter for dialysis. But this is not dialysis, okay? This is for plasmapheresis. Sorry if I'm using the dialysis term, but that's exactly what it is. Any questions so far? Okay. So far we discussed drug therapy, IVIG, and plasmapheresis, and then we discussed the complications related to both options. And here's the surgery. Remember the thymoma earlier? So if the patient does show up positive for thymoma from the CAT scan, again, this is only a small percentage of patients with myasthenia gravis. Not all of them have thymoma. So if they discover one, then they'll have surgical removal of that. So it's thymectomy. And this is where it comes now. So I told you earlier about the side effect, right? Which is going to increase the secretions. Okay. And what drug is used again? Because pyridostigmine comes PO, and this is a surgical patient. What drug do we use? Neostigmine. Okay. Neostigmine is the IV. And here's myasthenic and cholinergic crisis. So it's easy for myasthenic crisis. The treatment, of course, is we're going to give the the well, no, actually, the patient in myasthenic crisis, you may think that we're gonna give more anticholinesterase inhibitor drugs, right? Because this is a condition wherein they didn't have enough. Okay. Yeah. So we did the Tencelon and it improved, right? However, during a myasthenic crisis, we typically do not give the anticholinesterase drugs. The reason is it causes a thickening of their secretions, which will complicate their respiratory status, because they will be intubated here, because the Yeah, the weakness is so severe that they go into respiratory arrest because the diaphragm is so weak they'll have problems breathing, right? So we'll intubate them. We actually hold off on the anticholinesterase medications while they are intubated. Yeah. So what we'll do is just give the others the steroids, high dose steroids, and we'll give them the for, let's say, they undergo plasmapheresis or IVIG infusion. That's it. No anticholinesterase inhibitors during myasthenic crisis. Okay. Once they get better, then we can resume the anticholinesterase inhibitor drugs, but not during the acute crisis. All other drugs, though, are used. As far as cholinergic crisis, then it's easy. You have too much, so definitely, are they gonna give any more? No, definitely not. But same thing, we still intubate them, support them, of course. So they're having a severe episode, so they'll receive, steroids and um, what else? Yeah, the plasmapheresis, it's all that. All right, diet. If they are having difficulty, of course, we need to modify it. So they'll be on mechanical soft diet, so it's easier to chew and swallow. And that's it.
For eating is the same 30 minutes for eating, anything for eating?
Yeah, so of course, before eating, you have to still give the drug 30 to 60 minutes before. Here's your summary of your common signs and symptoms, the bulbar, in addition to your bulbar symptoms. This is what I mentioned earlier. Why again is pulse oximetry not helpful?
Because of the weak muscle.
Okay, the respiratory depression here is caused by the diaphragm weakness, not a problem with the lungs or the heart. Okay, so your pulse oximetry is useless here. It doesn't really assess the patient's oxygenation status fully. So you're better off with forced vital capacity. Right. And here's the summary. Questions again. Don't forget the side effects or complications listed under IVIG and plasmapheresis. These people are at risk for illness because, again, they have an autoimmune disorder, plus they may undergo plasmapheresis, so they are at risk for infections. Make sure they get their flu and pneumonia vaccinations. Any questions on myasthenia gravis? All right, let's go to the last one for today. Let's go to immune disorders, connective tissue, rheumatoid arthritis. So this is another autoimmune disorder, page 386. Common knowledge would say rheumatoid arthritis is a disease of the older person. Not really. Younger people can develop rheumatoid arthritis. It is a autoimmune disorder affecting connective tissues, particularly your weight-bearing, no, not only weight-bearing, but your fine motor joints, okay, your smaller joints. Osteoarthritis affects your weight-bearing joints, most of the time anyway. But rheumatoid arthritis can still affect your knees, your hips, but basically most of the victim joints of rheumatoid arthritis are the fine motor joints, the joints in your fingers, your wrists, and sometimes in your shoulders, like I said, hips and knees, but more concentrated on your upper extremities, your fine motor joints, your smaller joints. So we have a description here, which is chronic systemic autoimmune inflammatory disease. Rheumatoid arthritis typically is symmetrical right here, unlike osteoarthritis, wherein it can only affect usually one knee, or if it affects both knees, one knee will be worse than the other. In rheumatoid arthritis, it's symmetrical. Both knees on both sides of the body will be affected. So if it's the wrist, it'll be both wrists. If it's the shoulder, it's both shoulders. Okay? It's symmetrical. So what we do is, here's the pathophysiology. The patient's antibody develops antibodies against their joints, leading to synovial tissue damage. So they attack the soft tissues in the joints, leading to deterioration of the joint, and therefore there's swelling, there's edema, pain, and no more cushioning. Okay, it's very hard to move the joint. There's extreme pain. This results in disability and debilitation. Our goal here is, of course, to slow down the inflammatory process. There's no cure. I mean, it's an autoimmune disorder. So it will, as the description says here, it's this chronic systemic autoimmune disease. So there's no cure for this. We can, however, delay its progression. That's all we can do. So here are the mostly affected joints. They're more visible, obviously, in the hands and fingers. Over time, especially if the patient thinks, oh, I'm too young to start these treatments, I'll wait until later. Well, when you wait until later, there will be deformities of the joints now. So you'll have, look at this picture right here. Or, no, if they have better pictures, right here. Look at this figure 20.6, page 388. If your fingers are like this, now tell me, how are you going to open the doorknob? How are you going to write your name? How you gonna use your iPads? How can you do the paperwork after you do number 2, the toilet? And so on. Right? It's debilitating. You're pretty much disabled. I mean, how do you use these hands? Well, yeah, if you force it back, yeah, it's extremely painful. But these are permanent deformities now. There's surgery to repair them, but that's not going to be one surgery. There will be a series of surgeries. Plus, it's no guarantee that it's not going to come back because, again, this is a chronic inflammatory disorder. So this is what we call a swan neck deformity. Looks really, literally looks like a swan neck by the way it's bent. And this is a different deformity, boutonniere. And you have the ulnar deviation here. This is very common, so are these. These may... Yeah, it's the joint. The joint is deformed, right? Because the antibodies are attacking the soft tissues around the joint, causing the deformity. These patients will manifest with a lot more than the joints, but more concentrated in the joint. There will be synovitis or inflammation of the joint. Very painful. Most people will have other connective tissue disorders together with it. It's not only going to affect your hands or joints. Some people will have other connective tissue complications like scleritis, the sclera, the whites of your eye, because that is still connective tissue. Pleuritis, the lining, the sac around your lungs, that's the pleura. those are also made of connective tissue. So that's also possibly affected. Fluids can accumulate there. The pericardium, the sac around your heart, is also connective tissue. It can also be affected by rheumatoid arthritis.
So the main thing for this is the connective tissue.
Yes, but unlike lupus, wherein it will affect the entire body system, rheumatoid arthritis is mostly confined to the joints. But few people, like I said, may have these other connective tissue affected as well, namely the eyes, the
The lung.
the sac around the heart, and the lungs. How do we diagnose it? Very hard to diagnose. There is no specific test to rule out rheumatoid arthritis. So most of the diagnosis is made based on the patient's clinical symptoms, the how long it's been going on, the pattern, especially if it's symmetrical, for instance. Because these tests that they mentioned here, for instance, the anti-nuclear antibody, are not specific to rheumatoid arthritis. I mean, other autoimmune disorders have a positive test for those as well. So it's not really that easy. Here's a comparison between osteo and rheumatoid arthritis. For osteo, it's more of a wear and tear thing. So nurses are very high risk for these because we do a lot of bending, twisting, pulling, pushing throughout our careers. So we will have a lot of abuse on our joints, namely our hips and our knees, especially if you don't follow good body mechanics. You'll end up with osteoarthritis. Or if you're lucky enough, you'll have both. You'll have osteo and then complicated by rheumatoid arthritis. In osteo, the morning stiffness is about less than 30 minutes, and rheumatoid arthritis longer than that. It's almost like a all-day thing. For osteo, it's not related to autoimmune at all. Again, it's wear and tear. So construction workers, RNs as well. We might as well be working construction. And the joints involved in osteo, like I mentioned earlier, it's really the large weight-bearing joints. We are on our feet pretty much the entire 12-hour shift. Whereas look at the joints affected by rheumatoid arthritis, these are the smaller joints. And like I said, symmetrical in rheumatoid, not so in osteo. Osteo may only involve one joint. And there is, like was described earlier, so the eyes, the lungs, and the heart uh, um, membranes are affected here, not so in osteoarthritis. So I think this is on the, yeah, remember there's a item here on your exam 2 blueprint comparing osteo from um, rheumatoid arthritis. Here are the tests I mentioned earlier. So ANA, ESR, CRP. ESR and CRP are inflammatory markers. They are, again, not really exclusive to rheumatoid arthritis. In fact, we use CRP, ESR in people with infections. We use them to evaluate response to treatment because they are elevated in the presence of infection or inflammation. Let's start with non-pharmacologic treatment first. The idea about rheumatoid arthritis is to keep the joint moving. It's easier said than done, especially in the morning, wherein the stiffness prevents you from moving the joint. They're extremely painful. But we have ways around that. We can do warm showers, for instance, to loosen the joints. Plus, of course, the warm temperature there helps reduce the inflammation. So once you get the joint moving, it's better to take it from there. Definitely, though, when these patients are having a bad day, meaning they're having um, an attack, an exacerbation, is exercise the best? Is this the best time for exercise? Impossible. It's extremely painful. So pain management and anti-inflammatory treatments is your mainstay during periods of exacerbation. But as much as possible to prevent an exacerbation, patients must maintain mobility while protecting their joints in the process. However, when you're doing exercise, make sure the patient understands that um, they shouldn't exercise to the point of fatigue or pain. So just take it easy, right? Aerobic exercises, again, just keep the joints moving. If you keep them moving, just like the saying, a body in motion tends to stay in motion. That just follow that principle. Nutrition is also good. Obesity will not help here. Patient gains weight, that'll even be harder on the joints. Most of your questions will be on pharmacology. There are a lot of drugs involved here. Mainstay will be NSAIDs. These patients don't respond well to opioids. The pain here is inflammatory in nature because the joints are swollen, they're inflamed. So no matter how many opioids you give them, how many doses, they'll just cause side effects of constipation, sedation. It won't help really with long-term pain relief. NSAIDs here are the mainstay for pain management. What do you foresee as potential problems? Because these patients, again, will be relying on NSAIDs. So we're talking 6 to 8 pills here a day of NSAIDs. One is renal problems. What else? GI problems? Yeah. Ulcers and bleeding. Okay. What else? Cardiovascular, right? Remember us talking about NSAIDs in heart failure? Okay. On top of NSAIDs, we will be giving steroids for daily, just like in myasthenia gravis. Low dose will be your daily maintenance. If they having a exacerbation, then we'll give them high dose steroids. So they even given PO, IM, IV. Now let's go to disease modifying antirheumatic agents, or DMARDs. One drug under DMARDs is hydroxychloroquine. This is very famous now since Trump touted this for COVID-19. Anyway, regardless of what he's saying. So this is used only for, number one, lupus, and then another use for it is in rheumatoid arthritis. It's true that it does have cardiac side effects, so be careful. We have sulfasalazine, tofacitinib. These are all disease-modifying drugs, meaning this will actually decrease the progression or slow down the progression of RA. Methotrexate is the cheapest alternative. Methotrexate can be by mouth or IV, but not all people tolerate methotrexate. And besides, if we're talking about a younger woman here, methotrexate is teratogenic, so pregnancy is contraindicated for methotrexate. But it's the cheapest drug out there to modify RA. Hydroxychloroquine is also affordable, but again, the problem there is the cardiac dysrhythmia side effects. Here's a summary, table 20.3. You have methotrexate, sulfasalazine, hydrochloroquine, leflunomide, and tofacitinib. We have biologics, which are also quite expensive. Where's 20.4? 20.3. Okay, right here. 20.4. You've probably seen these on TV. Biologics are pretty much immunosuppressants. Makes sense because RA is an autoimmune disorder. So if you suppress the immune system, will it continue making antibodies to attack your joints? No. How do they work? Well, they kind of work too much. That's why if you see on TV, for instance, adalimumab, Humira, this thing, the warning is before starting Humira, make sure your doctor tests you for TB or tell your doctor if you have TB or are prone to having TB. So that's how low it suppresses the immune system. It suppresses it to the point that you are now susceptible to TB. We just concluded TB. So who's prone to getting TB? So you're at that level as a homeless person, for instance, or an HIV person. That's how low your immune system will get when you're on these medications. So biologics aren't really your first line. So as mentioned already here, first line are methotrexate, hydroxychloroquine, sulfasalazine, or Xeljanz, tofacitinib. Xeljanz is not an injection though. That's a pill. So I wasn't kidding when I said there's a lot of medications involved for rheumatoid arthritis. Here's your warning for methotrexate. So we have, I mentioned pregnancy. So make sure you're not pregnant and then you stay non-pregnant while taking methotrexate. So to avoid that, what do you do? Okay, contraceptives is very important. You don't want, I mean, you'll get pregnant, but what will happen to that child? Yeah, very deformed. I don't know if he will even survive. Okay.
So it doesn't affect any form of contraceptive anymore?
No, you just make sure you're on contraception. Here's another one. Take folic acid to prevent oral ulcers, avoid alcohol, and renal insufficiency will require lower doses. It's also toxic to the liver, so make sure that's being monitored. Surgery definitely is not a first line also. It's only done if the patient is really in severe pain or is totally disabled and then they're still young. In the elderly, they typically don't bother with surgery anymore. Like I have an aunt in, where is New Bern? That's North Carolina, right? Yeah, I think she's in, she lives alone in North Carolina. And she has the swan neck deformity and the ulnar deviation. She has that, but kudos to her. She still lives independently. She refuses. Yeah, her kids want to go there, take care of her, or kids asking her to live with them. She said, "No, I like my independence." She lives alone in a smaller house. She used to live in a huge house in Jersey. Then she moved to a smaller house close to her favorite son. Remicade is an IV infusion. This is you guys, if you become nurse practitioners, you will be infusing these frequently. So this will be directly injected into the joint. involved, Remicade. All the others are sub-Q.
For steroids that they take, is it done into the joints or is it oral?
There are steroid injections, but they're temporary relief. I mean, that's only for that will probably buy you 2 months of pain relief, and then you go back again for another injection. But that's not really advisable because it won't. I mean, it won't modify the disease at all. It's all purely symptomatic. And that's it for rheumatoid arthritis. So a lot of medications. The thing about these here, of course, if a medication is injectable, say sub-Q, what do you teach a patient, therefore? Because they're the ones administering these. This doesn't have to be administered at a clinic. All right, so you teach them, yeah, how to administer subcutaneous injection, what to do. What about IV? Can they give themselves IV? No, of course not. That will be administered by a professional, by a provider. But all the subcutaneous routes, they're all taken by the patient themselves.
Okay, so these medications that you're talking about, can you teach us what is coming? Because this is a lot of medication for these people.
I can't really pick out because all of them are used. From Remicade down to Orencia, these are all used. I mean, providers will, yeah, pick a certain one over another, but all of them are in use. In New York, these are all available. What? I just told you that. So if you're asking, let's say, what is TNF? What is tumor necrosis factor? Or interleukin-6? What are these substances? These are cytokines. These are pro-inflammatory cytokines, meaning these are the substances in your immune system that trigger T lymphocytes, B lymphocytes. So instead of attacking your or inhibiting your T lymphocytes or destroying your T lymphocytes, because again, these cells in your body are the ones attacking your joints. Your own T lymphocytes, your own killer cells are attacking your joints because you have an autoimmune disorder. So the idea here of giving these biologics is, why not inhibit the substance that stimulates the T lymphocytes? Make sense? Because the cytokines are the ones stimulating your immune system to make them grow, to release them. So inhibit that substance, and then you'll inhibit the T cells indirectly. So therefore, no more symptoms. Make sense? And plus, these are not, again, have you ever heard of adalimumab elsewhere, like in psoriasis? These are also used in psoriasis, in Crohn's disease, because these are all autoimmune disorders. So they're not confined to rheumatoid arthritis. All other autoimmune disorders will receive similar medications. Any questions? Alrighty. So quiz next week is from